Hello friends, this is a case of laparoscopic cholecystectomy, appendectomy and ovarian drilling in the same patient. And we will do cholecystectomy by Mishra's knot, that is one of the best extracorporeal knot, and we will apply on the cystic duct Mishra's knot, and appendix also we will apply Mishra's knot. We can see these are the 4 port we are going to use for all the 3 surgery. One will be for telescope, second will be epigastric port for right hand, third will be fundus grasper for the left hand, and fourth will be for assistant to hold the fundus, and third will be for herdsman. So, this is a very simple case and we will do the performing this procedure. And why Mishra's knot is important, I will tell you later. So, let us start doing this surgery, and we will use the varus needle technique over the inferior crease of umbilicus. So, 2 Ellis forceps should be applied on the either side of the umbilicus, and purpose is that it will evert the crease of umbilicus. We do not use Ellis forceps to lift the abdomen, and the varus needle we will use 12 centimeter varus needle over inferior crease, and just giving one a small stab wound over inferior crease, just 2 millimeter stab wound. Later we will enlarge it, and we will calculate the thickness of abdominal wall plus 4, and that much part of the varus needle should be naked. Put it into the wound and lift the abdominal wall, and it should be perpendicular to abdominal wall but oblique to the body. And here you will get 2 click. This is the 1 click, this is 2 click. After that we will take a syringe, and here it is going the irrigation test, suction test, and this ball of the varus needle will sink down, and that is called hanging drop test. So, all the test is over. After that we will attach the tubing of the insufflator. Here we are keeping the preset pressure at 15, and we will wait for actual pressure to reach to 15. So, we can see this homogeneous distension is started, and once the actual pressure will reach to the preset pressure, flow will stop. After that we will enlarge the incision and put the first port. So, this is the 26-year-old female with having infertility as well, and she has the secondary infertility, and she has the gallstone, multiple gallstone, and there was one episode of appendicitis also before. So, we are going to perform cholecystectomy, appendectomy and the ovarian drilling. However, the ovarian cyst PCOD is question mark, but this is polycystic ovarian disease. So, we will do that, and we will do diagnostic also. We will see the cul-de-sac, I will show you uterus, triangle of Drome, ureter, endometriosis also we will try to find out. So, it is over, and now we are taking the varus needle, and now this incision will be enlarged either side to make it 11 mm. So, this is called a smiling incision. One of the biggest advantage of a smiling incision is that a scar will be virtually invisible, and then we are dilating the obliterated vitreointestinal tract, and that is a part of a Scandinavian technique. And now we have the trocar. Betadine is at the tip. Head of the trocar should rest over thenar eminence, middle finger should wrap around air inlet, index finger should be pointed towards the sharp end. In the World Journal of Laparoscopic Surgery, one published literature that putting the betadine over the tip during introduction of the trocar will decrease the risk of infection. So, there is no problem, we are putting always. Here we can see hissing sound is started. Take the trocar out and then introduce the telescope. After that we will have the first view of the gallbladder, and now we will palpate with the right hand, we will palpate the GP sternum, and with the left hand we will keep the thumb just below the GP sternum. It is just, and then we will with index finger, we will put the left index finger and we will give the incision, that is transverse incision on the midline for our second port, and that will be also 10 mm. Advantage is that you can use the clip applicator, or you can tie the knot if you want to tie the knot. Even the 5 mm is enough, but we will use 10 mm because we will apply clip over the artery. However, you can tie the knot also over the clip. This is the third port, that is the mid-clavicular line just below the costal margin, and this your assistant, you can give to the assistant to put it. These are 5 mm. So, this is the third port, and now fourth port in the anterior axillary line at the level of umbilicus or 7.5 centimeter lateral and 7.5 centimeter below the third port. So, all the port is introduced. After that, we will tell the anesthetist to put the patient head up and right up, head up, right up, and then fundus grasper will be introduced. And now the assistant will hold the fundus of the gallbladder with this fourth port, and he will retract it towards the right shoulder. So, this is holding the fundus of the gallbladder and retracting towards the right shoulder. So, it is done. After that, we will hold the Hartmann pouch and we will retract it anteromedially. Here we can see this is the porta hepatis and this is the Rovier sulcus. This is porta hepatis, you can see, and here this is the Rovier sulcus. Rovier sulcus is very important landmark because it will give you, you should never go below the Rovier sulcus, otherwise you are damaging the CBD, and we will start the posterior peritoneum dissection. This is the anterior peritoneum and this is the anterior one and this is the posterior. So, laparoscopy, any laparoscopic surgery start with the peritoneal incision. Here was one stone in the Hartmann which we are trying to milk it up and then trying to hold the atraumatic grasper and giving the anteromedial traction. And now we will start the posterior peritoneal dissection. And once you start dissection, you should leave 1 millimeter of the peritoneum towards the liver. Don't touch the liver and don't go more nearer the gallbladder as well. So, only 1 millimeter away from the liver you will start the peritoneal incision, and continuous anteromedial traction should be given. Then automatically areolar tissue plane will form and at least 1/3 of the gallbladder should be separated, the peritoneum should be separated before going anterior. Why in posterior is first, I have already discussed in my textbook in the detail and in the lecture. So, already you must knowing that, and here it is 1/3 of the gallbladder posterior peritoneum is separated and always above the Rovier sulcus. Now, same way we will give anterolateral traction and then posterior peritoneum will be separated. During that also we should avoid touching the liver 1 millimeter away from the liver and then giving the traction anterolaterally has advantage, gallbladder will not puncture, and we can see the cystic plate is open and this is the posterior window is formed. After that you will separate the peritoneum over the cystic pedicle, that is very small. You should only hold the peritoneum, and if you are using hook, then always remember hook, look and then cook. Always more than 6 millimeter area should not be taken at one time in the hook if you are using, and more than 40 watts should not be. Here we are using harmonic, and keeping the Teflon jaw of the harmonic towards the gallbladder has a advantage that it will not allow the gallbladder to puncture. Our purpose is just to skeletonize the cystic pedicle, nothing more than that. Energy should always be used only for peritoneum, rest of the window you should make it by blunt dissection. So, this is just the peritoneum over the cystic pedicle is separated, and after that same we will separate anteriorly. Care should be taken that thick tissue should not be held, otherwise artery can puncture, it will start bleeding. So, you superficially you should only try to do that. That is all. The purpose of harmonic is over. Now, there is no need of harmonic. you should try to do all blunt dissection. Better to remove the harmonic and bring a Maryland, because Maryland is one of the best dissector. So, this part is over. After that, here we can see that this is the CVD. Now we are bringing the, and here this is the lymph node of Lund. We can see this is the lymph node of Lund, and this is the anterior window. You can make the posterior and anterior, and always open parallel to the tubular structure. Whenever you open the Maryland, open parallel to the tubular structure. We can see posterior window already we have formed here. This is posterior, this is anterior, and we can see critical view of safety is visible. Two structure is clear cut entering into the gallbladder with the two clear cut window. We can see CBD, you can see cystic duct, you can see cystic artery, you can see posterior window, you can see anterior window. So, this way you should have the critical view of the safety should be cleared. If you want, you can enlarge the cystic plate further, but I think for our purpose that much dissection is over. Why to unnecessarily do the more dissection? After that, we will bring the our knot. ICG mode also you can do, and with the ICG mode we can clear. We always routinely give indocyanine green to our every patient who perform the cholecystectomy. We inject 45 minutes. So, this is the ICG. You can see cystic duct, CBD, all is visible in the ICG mode. After that, here we are bringing the one uh, number one vicryl, and this vicryl is very good for Misra's knot, and we will use Vandarkar knot pusher. So, you can keep the tip of the vicryl towards the concavity of the Maryland, and just you can enter inside. After that, you can feed it 4 times, so that at least 20 centimeter of the vicryl should be inside. 1, 2, 3, 4, 5, every time 4 centimeter. After that, we can catch the tip of the suture, bring it out and tie the knot. And this is the very easy knot. You will put shorter above the longer, and then you go from below up. This is the single hitch, then this is the first wind, then this is the first lock, then this is the second wind, and this is second lock, and this is final wind, and this is the final lock. So, this is a very simple knot, very secure, up to 18 millimeter structure, even for pedunculated myoma, even for IP ligament, even for the any tubular renal artery, splenic artery, all this knot is very secure compared to rudder knot. Rudder's knot configuration is 131, and here configuration is 11111. Another big advantage of this knot that it can never go to the CBD, because by default it will slip to the narrow structure. It cannot go to the CBD, and it is very strong. After that, you can cut this suture, and one single knot is always better, because knots are either exactly right or hopelessly wrong. They are never nearly right. Now, we are applying one clip over the artery. If you want, you can apply the knot also over the artery, but not particularly over the duct has advantage that there is no chance of cystic duct clip stone. Cystic duct clip stone is also called cat eye stone. Other advantage that it cannot slip, only one knot is more than sufficient, and now this is one clip we have applied towards the gallbladder just to prevent the leak of the bile. After that, you can cut the artery by the harmonic, because we are using harmonic. So, one clip over the artery is enough. And artery is separated. After that, you can separate the duct. And now we will hold just below the clip and slowly keeping the areolar tissue plane, you can separate the gallbladder from the liver, and anteromedial anterolateral traction should be given over the Hartmann pouch. During separation, always cut the peritoneum first, then automatically areolar tissue plane will open. And once we dissect the half of the gallbladder, after that we tell our assistant to remove the fundus grasper because it will disturb you. And we need traction in our hand. So, slowly now it is separating, and these are the peritoneum which will be separated. And now again we should hold it below the more nearer to the liver to optimize the traction, and remaining gallbladder will be separated from the liver. Always better to keep the Teflon jaw towards the gallbladder so that it will not puncture, and always keep the vibrating jaw of the harmonic under vision. So, this is reaching over the fundus of the gallbladder. Here we can see some of the little part of the fundus of the gallbladder is intrahepatic. So, you have to be careful because maximum number of the rupture of the gallbladder happened at this part here, maximum. So, you have to be more careful in this part and just catch only the reflected areolar tissue plane and cut the peritoneum, and the hair traction should be given towards the right hypochondrium. So, this is final cut. After that, you can lift the gall lever and you can check for the duct of Luska, cystohepatic duct. We can see there CBD is also visible, ICG mode is on, and you can see this green. You look at, I will show you the power of this knot. See here, I am pulling it and this is never slipped. This knot is very strong. I am trying to slip it out, but it will not slip. So, this is a very secure knot. After that, it is over. And now for the time being, we will keep the gallbladder in the right hypochondrium, and then we will hold the tinea coli, and now telescope is transferred to the epigastric port, and we will use the umbilicus port for the harmonic. So, we can see this patient has some adhesion over the omentum, but that is not our concern, that may be due to the previous cholecystitis, and we are doing the appendectomy. Here you can see appendix is quite large, and there was a request of the patient to do the appendectomy also, because someone has told before long back that there was appendicitis. So, this is slowly separating the major appendix from the appendix. This is harmonic. So, no problem if you are using hook, then be careful that metal part of the cannula should not touch the metal part of the hook, otherwise direct coupling will happen. So, we have reached up to the tinea coli, and that is all. After that, again this is the another Misra's knot with the same vicryl which we have used for the cholecystectomy. The remaining you can tie the Misra's knot, and after that here you can hold the appendix and bring it out through the loop, and then bring the tip of the knot pusher over the base of the appendix and keep it over the cecum, and automatically the entire knot will slip there. Do not keep it over the appendix, do not keep it here, keep it over the base, and then automatically you will have the complete appendectomy. There is no chance that you can do the incomplete appendectomy. And this is the power of the Misra's knot, that wherever you will put it, all the loop will shrink there only, and you cannot leave, even the 5 millimeter of appendix cannot be left behind. And now we are cutting the appendix together with the suture together and leaving 5 millimeter over the base, so that a good dumbbell will happen, and then you can remove the appendix. Take care, the tip of the harmonic should not touch the cecum. And it is done. For the time being, we will keep appendix. Here remember upper part is also sealed, so there is no chance of contamination, because harmonic will seal the either side. You can do even appendectomy harmonic clipless also. If you search in the Google, clipless appendectomy also people they do, but we never do clipless because we use harmonic second time also. So it is not recommended in India. Now this is the uterus. Here is the, you can see there is a one cyst and some polycysts are there. So here we are using PCOD needle, that is polycystic ovarian drilling needle. This needle has advantage that it is hidden. Until you press, it will not come out and you will not have a chance that it will prick the wrong place. So this is hook look, and here you should take care, only 4 poles should be punctured, only 40-watt current should be used, only 4 millimeter deeper you should go in the ovary, and only 4 seconds you should press the paddle, and it takes approximately 4 month time for the hormonal function to get returned to the normal. So this is just with the blunt tip you can rearrange the posterior wall, and this is also drilled. So this is over, you can see fluid is coming out, and one more we will drill here. That's all. After that, this is the median umbilical ligament and this is the medial, and both the side inferior epigastric vessel also you are seeing. This is median and this is inferior epigastric vessel of the right side, and this is the deep ring, this is the round ligament. So all the structures are clearly, this is the inferior epigastric vessel of the left side, that is also visible. This is the triangle of doom, this is the deep ring, here is the round ligament. These are the iliac vessels in front, and this is the triangle of pain, and all the structures diagnostic you can do. And light cable right now is down, so we are seeing up. This is the iliac vessel here, external iliac artery and vein. This is the triangle of pain where LFCN and GFN will be there. This is GFN, genital branch of genitofemoral nerve, and laterally will be lateral femoral cutaneous nerve of the thigh. So this is triangle of pain. Here is the ilium and this is the triangle of pain. So these structures already you know, but here just for our student we are doing the diagnostic. So this is the psoas muscle over which it is sitting, and this is the LFCN nerve. GFN is also visible. This is GFN. That is the most lateral part of the pelvis is GFN for the female. And here we have the round ligament. This is the iliac vessel, and this is the area of the aberrant obturator vessel, corona mortis vein. In this area will be there, and laterally you will have Cooper ligament. Here we can see this is the IP ligament, and if you will push the sigmoid, this is sacral promontory. Telescope is little rotating, assistant is keeping the camera little rotated, that is why uterus is rotated. Here you can see ureter, and this is the ureter. If you will wait for few seconds, you can see here peristalsis is about to start, and this is peristalsis of the right ureter is visible. After that, here this is ureter. Look at this again. This is a sacral promontory. I don't know why assistant is rotating. This camera is good now. It was badly rotated, so we should not rotate the camera. Here this is the sacral promontory. This is the sigmoid colon, and again he is rotating the camera. This is the round ligament, and this is the deep ring on the right side. This is the round ligament, and this is the deep ring, and here you will have the, yes, now camera again he is rotating. So this is bad. So okay, anyway, this is the deep ring and this is the iliac vessel and this is the triangle of pain. So here will be inguinal ligament going like that. This will be the area of the inguinal ligament, and this is psoas muscle. So this is the lateral pelvic wall of the right side, and now we will go to the left side. This is the medial umbilical ligament, and this is the inferior epigastric vessel which is originating from the iliac vessel. Again rotated. So this is now correct. So this is the aberrant outwarded vessel, and this is the IP ligament. You can lift the IP ligament if you want to see the uterus, and this is the ureter. Again, this is the peristalsis of the right ureter crosses external iliac vessel, left ureter crosses common iliac vessel. So right will be little more lateral. So this is the sigmoid, and here is the sacral promontory. So now this was diagnostic. Now again telescope is transferred to the umbilicus, and from the epigastric port we will take the gallbladder out and then appendix out. And remember, appendix tip is cut by harmonic, so no fecal matter, and it will get sealed. So even it will not contaminate. Just like if you are cutting with the scissors, you should not drop. And now here is the, we will hold the neck of the gallbladder with one artery forceps. After that, with the knife, we will keep the sharp edge of the knife, and you can cut the neck of the gallbladder, and you can put a suction inside, and you can suck all the bile. Once you suck the bile, automatically the gallbladder will collapse, and all the small stones can be sucked out, and it is out. If it is large stone, you have to put ovum forceps to crush it. You may use endo bag also. After that, this is the appendix also taken out. So thank you very much for watching this video. Have a nice day.